I want to talk about collaboration. And I'd like to talk about collaboration on a couple of different levels. I want to talk about collaboration within our own units, how we do that, and also how we collaborate across units to make things better for all patients with BPD. So let's start by talking about collaborating in our own units. How do we do that? And it's really important to do that. And when I say collaborating in our units, I mean with everyone. So first and foremost, with everybody that's in the unit every day, the nurses, the advanced practice providers, the pharmacists, the social workers, the therapists, the respiratory therapists, so that we can improve the outcomes of these patients. And I also mean collaborating with our colleagues from pulmonary, from cardiology, from endocrinology, from whatever ology you want to say, because BPD is really a disease that affects the whole patient. And BPD is a pulmonary disease, but we often think of our unit at Nationwide Children's as a developmental unit. We often think about how we can improve development for our patients. And that's because it's been shown repeatedly that BPD patients are at high risk for neurodevelopmental impairment in the long run. This is a slide from a scoping review that was done where they looked at IQ scores in preterm cohorts compared to term baby cohorts. And they found that the IQ scores were worse in cohorts that had more BPD patients. So this is a slide from the scoping review that was done where they looked at IQ scores in patients with that were born preterm. They compared them to term babies, and they found that the more patients with BPD that were in the cohort, the worse the IQ scores were. And so why is that? Why are IQ scores worse? There's lots of, or why is neurodevelopmental impairment part of BPD? There's lots of different hypotheses in literature about that. One is that patients with BPD are just the sickest patients. Another is that BPD patients, the preterm babies that get BPD, have a lot of comorbidities. They have things like IVA, necrotizing enterocolitis, sepsis. And a third is that BPD patients undergo things physiologically that aren't good for them. They get hypoxemic, they get acidotic, and things like that then result in neurodevelopmental impairment. But we would argue that there's a fourth hypothesis that we should look at, and that is that the standard model for treating BPD in NICU is developmentally inappropriate. It contributes to neurodevelopmental sequelae. By that, I mean that we're neonatologists, we're intensive care doctors. We would like to see our patients get better. In fact, we'd like to see our patients get better really quickly. But BPD is a long disease. It's a chronic disease. It doesn't go away quickly, and it doesn't get better quickly. And so some of the things that we do completely appropriately during the acute phase of the disease don't really work in a chronic disease like BPD. But collaboration is really, really important. And so in the BPD unit at Nationwide Children's, we have a large group of people that come through, including the neonatologists, including the nurses, including advanced practice providers, all that are specific to the BPD unit. We have a lot of other subspecialties that come through. But collaboration is really key. We have a lot of therapists that come through. Our patients are often not in the bed. They're often on the floor on a mat getting a therapy, which is really, really good, even if they're intubated. And it's really important to have a collaboration because BPD is a long-term disease. It's going to take a long time for things to get better. And it requires long-term care. And a lot of times, intensive care doctors like us, neonatologists, aren't really good at long-term care. And so getting help from our associates who are more used to long-term diseases is really, really helpful. And then finally, it's a huge stressor on the family. Learning how to communicate effectively with them is so important, as Mary just talked about so eloquently. But learning how to tell them what their baby has and how it's going to last and how it's going to happen is really important. And intensive care doctors really are very good at that. So really having a cadre of people that can help you with all of these kind of problems that are relatively unique in the NICU setting to BPD. And there's some other chronic diseases, shortcut with neck and really bad IVH and muscular dystrophies. But there are other chronic diseases, but the most common one by far is bronchopulmonary dysplasia. What are the principles of care for BPD? Well, it's really important to use the principles of chronic care. And by that, I mean that we want to minimize disruptions to the patient. So a patient who is 36 weeks PMA or greater, you really want them to start developing. You want them to start doing the things that they're supposed to be doing as an infant or a baby. Start taking the bottle, start interacting with the parents really well, start doing all of those kind of things. But if you're getting a blood gas every 4 hours, or if you're drawing labs, or restarting an IV, or sending a patient down for a CT scan, getting another X-ray, that's a constant disruption for the poor patient, and probably results in some neurodevelopmental alterations that may go on to lead to impairments in the long run. So it's really important to try to minimize those disruptions, to try to make it as much like being at home as you can for the patient with BPD. Obviously, that's not exactly possible, but if you can make it as much like being at home as you can, it'll be much better. So if you have the parents involved, if you can have the patient feel like they're in their own room, that they have their own bed, that they have their own things, that they have their own routine, those things matter a lot to these patients going forward. The other thing that's important to remember of BPD is there's not a lot of good evidence on how to take care of these patients. There's really no gold standard studies on looking to which drugs to use, which ventilation strategies to use, what nutrition strategy to use. There's really no really good gold standard trials in BPD. So we have to use the best available evidence to then develop best practices for these patients going forward. And I'll just take a little sidestep here. We've developed this idea of trying to minimize distractions. And so over the years, we've become less reliant on blood gases. And in fact, we now almost never draw blood gases on our patients. And people, when they ask me about BPD, they say, well, what PCO2 do you shoot for? And I say, well, I don't know, I don't draw blood gas. But what I do shoot for is that the patient with BPD on the ventilator is comfortable. They're not working really hard to breathe. And they have an FiO2 that's reasonable. And so it's really important to look at the patient and see how they're doing. If they're awake and alert and can interact with their environment, that's really what you want. And it doesn't really matter what the PCO2 is. It really matters that the patient's awake and alert and interacting with their environment. So it's really important to think about that, and to think about ventilation in terms not so much of the blood gas, but of how the patient is reacting to what you're doing. So this is our data. We looked at routine blood gases in patients from 2014 through 2020. We found that the 62% of a cohort of 400 and something, 445, never had a blood gas once they had a diagnosis made of BPD at 36 weeks until they went home from the NICU, despite the fact that they're on mechanical ventilation or CPAP. And there was not really much difference in disease severity between the patients that had a blood gas and those that didn't. And in fact, when we looked at the patients who had a blood gas, the 38% of patients who had a blood gas, the median number of blood gases was only 4. And yet the median length of stay from the time of diagnosis at 36 weeks until they went home from the NICU was 125 days. So there weren't a whole lot of routine blood gases done, even on the patients that got blood gases done. So this isn't a randomized controlled trial. It's not gold standard evidence to show that, but it just shows our experience without using blood gases. We have reasonable outcomes for these patients. I am trying to get this stuff published, but so far the editors haven't much liked it. So I have to figure out a way to get it by the editors yet. And it's really important to have single-centered collaboration within your unit, within your NICU on BPD patients. That has to be sort of a first step in improving the outcomes of kids with BPD. But if we think of all kids with BPD and we think of moving the field forward, then single-centered collaboration is not enough. And I'll talk a little bit in the next couple of minutes about the fact that BPD definitions remain very subjective, and there's not really a good one yet. The incidence of BPD is increasing. It's not going away. I trained a long time ago, back in the last century, and we all thought that BPD would be gone by now with surfactant and inhaled nitric oxide and better newborn care and neonatal steroids. We thought we wouldn't have BPD. But the incidence of BPD is actually going up, probably largely to the fact that we are now really good at resuscitating patients born at the edge of viability. And we are neonatologists, so we are somewhat independent-minded. So our approaches to these patients varies dramatically. And not just between centers, but even within a center. So even our practices within a center, within our colleagues, tends to be radically different. So what is BPD? BPD was first described in 1967 by a radiologist at Stanford, Bill Northway. And he used radiological criteria as well as clinical criteria to define the disease. But 1967 is even longer ago than when I trained. And preterm medicine, neonatal intensive care is very different. And so Bill Northway described this chronic lung disease in patients that were born at 32, 33, and 34 weeks and had horrible lungs due to surfactant deficiency because they didn't have inhaled steroids, they didn't have surfactant, they didn't really have very good ventilators. And so if you look at the ventilator settings that they were using at those times, you would be a little bit taken aback because they're very different from what we do nowadays. In fact, 33 and 34 weekers in our current definitions of BPD can't have BPD because in our current definitions, you have to be born at less than 32 weeks to have BPD. So Bill Northway described it a very important disease and labeled the term or coined the term bronchopulmonary dysplasia. But the kind of patients he saw in 1967 or described in 1967, we don't really see much anymore. So we're still trying to figure out what the heck BPD is. Over the years, there's been different workshops, different groups got together at the NIH or other places and came up with different definitions. In the last 5 or 6 years, there's been probably 5 or 6 new revised definitions suggested. And I put 3 of them on the timeline here. But we still really don't know what BPD is. And so how do we diagnose BPD in 2023? It's pretty straightforward. I don't know, it's not a very good definition, I don't think, in terms of predicting those patients who are going to have long-term morbidities from their BPD. I don't think it's very good at identifying those patients that are going to have longer stays in the NICU or going to need tracheostomy and that kind of thing. We need to get better at that. And it's very subjective because it's based entirely on whether the patient's on supplemental oxygen or getting positive pressure respiratory support. And there are no national standards for how we apply those things, right? So every place, every person, every neonatologist, and it's very likely that that's true, every neonatologist probably applies them just a little bit differently. I don't mean to slam neonatologists, I am one, so. But we are very independent-minded, and so we tend to do things our own way. So there are no national standards for when to put oxygen on or when to take it off, when to put the patient on positive pressure, when to take them off. Having said all that, we diagnose the patient with BPD if they're born at less than 32 weeks, and at 36 weeks post-menstrual age, they're either on supplemental oxygen and or they need positive pressure respiratory support. If that's the case, then that patient has BPD by definition. Also, most of the definitions in the last 5 or 6 years have some kind of severity grading that they include. I like the one from the NICHD Neonatal Research Network that was published with Eric Jensen as the first author. It suggests that if you're only on a low-flow nasal cannula, you have grade 1 BPD. If you're on non-invasive positive pressure support, you have grade 2 BPD. And if you're intubated and on a ventilator, then you have grade 3 BPD. So the definitions are very good. So keep that in mind when I say that the incidence of BPD is increasing, because if you can't define a disease very well, it's kind of hard to know what the actual incidence of the disease is. But when people have looked over various time epochs or different times, the incidence of BPD does seem to be going up. And this is a recent paper from a group in Europe where they looked at the BPD incidence at 3 different time points or 3 different time epochs, and they found that the incidence of BPD is going up. And there was the highest in the epoch from 2018 to 2019. But as you can imagine, since we don't have a good definition, the incidence of BPD is very variable. And so we did a point prevalence study in the BPD Collaborative a few years ago. And we asked how many patients on a given day at a given time in your unit had severe BPD. And we found that in 8 academic centers across the country, large academic centers, that the incidence of BPD ranged from 10% to about 60%. And that's probably multifactorial, but it probably has a lot to do with the definitions as well. The current reality for, I said, we're sort of independent people as neonatologists. We like to do things our way. But the reality is that there is no evidence. So the current reality is that there is no evidence, so there's no standardization for what we do. And so this is from that same paper where we looked at 8 different centers, and you can see that the use of diuretics, inhaled beta agonists, and anti-reflux medications vary dramatically between these 8 centers. This is another slide that we recently published from the BPD Collaborative, where we looked at sort of who was getting what medicines during a point prevalence study that was done for looking at what kind of ventilator support or respiratory support patients were on. And then the first column here is the kind of medicine or the medicine class that we looked at. The second column of a bunch of figures there that are either blue or red are from patients who didn't get treated with severe BPD. And the last column is those headed by a yes, are those patients that didn't get treated with medication. And you can see in the last column, is those figures, those are mostly blue. And so most of the patients that got treated with medicines during this Prevost study were patients that were intubated. So if a patient's intubated with BPD, we're more likely to treat them. And again, I think that makes perfect sense, but does show that we're trying to still get those patients extubated. But this center variation, whether it's been medications or ventilator settings like shown on this slide, really is impeding our progress to make dynamic changes or important changes in the outcomes of patients with BPD. This is a recent Prevost study we did. Robin McKinney was the first author. He's a critical care doc at Brown and very interested in BPD. So what we did is we looked at what patients were on at a given day and at a given time across our different NICUs in 19 different units. And you can see that based on these vent settings that there is clearly no agreement across centers. And given the huge variability, there's no agreement within centers either. And this really impedes our progress, right? Because how would we do a study looking at two different forms of ventilation, see if one was better than the other, when there's like 19 different ways of ventilating? It's probably 19 to the third power or something because of those wide bars. So we really need to get to the point where we can collaborate across institutions. In 2012, Steve Abman, who's a pediatric pulmonologist in Colorado, and I thought that we should get a bunch of people together that were interested in BPD. So we went to the 2012, before the 2012 PAS, we put out this email asking people who wanted to join us for lunch to talk about BPD. And the PAS is a big meeting, and there's lots of neonatologists there, but we only got 12 people who wanted to talk about chronic BPD. So we started with 12 people from 7 institutions, and we started the BPD Collaborative that day. And since then, we've grown dramatically. We're currently 31 institutions in the United States and 4 international centers. The site PI from our center in Japan is here, and he's going to talk later. We're dedicated, the sites, you become a site in the BPD Collaborative if you have a multidisciplinary team that's dedicated to the care of these patients with severe BPD. And these institutions are dedicated to trying to improve the outcomes for these kids, these people. And what we've done is we worked on creating a culture of collaboration. And the first thing we worked upon was developing a registry. And that's taken time and effort, but we're almost to the point where we are implemented, but we don't have everybody involved yet. We really want to develop and disseminate high-level evidence. We want to do some of those RCTs I've been talking about that we need to develop the evidence to see what we're doing and if we're doing the right thing for our patients with BPD. We really want to work on disparities. We want to try to make sure that there's no disparities in outcomes for patients with BPD. And we want to we want to promote diversity within our organization and within the field of BPD medicine. We want to stimulate the careers and foster the careers of young investigators. And perhaps most importantly, we want to involve families in everything that we do, whether it's a new QI project, whether it's a new research project, whether it's trying to identify the problems with BPD that need to be studied. We really want to involve families in everything that we're trying to do. We have done some nice work. In 2017, we published a paradigm-shifting approach to the multidisciplinary care of kids with BPD. And it really did take a multidisciplinary approach. It included pulmonologists, neonatologists, cardiologists, nurses, APPs, pharmacists. We talked about everything from ventilator management to management of pulmonary hypertension to nutritional management to how to determine when a patient's ready to go home and what to do in that transition from care in the hospital to care in the clinic. And that's a huge transition because it turns out that a lot of patients with BPD have lifelong problems with their BPD. So they're going to need help from the pulmonologist, probably from the developmental behavioral pediatricians, probably from the cardiologist, long after they go home from the NICU. And I think that's one of the things that we kind of forget. As neonatologists, we kind of think we've done a really good thing when we send the patient home, which we have, don't get me wrong. But there's really a lot more to it later. And we really need to develop lifelong, or at least childhood-long BPD clinics where patients with BPD can get care. We've worked on changing the ventilatory paradigm. So as intensive care doctors, we really don't want to hurt the lungs. And I think that's the right thing to do, particularly early in life. You definitely don't want to hurt the lungs, and so you want to do this lung protective strategy. That's characterized by a low tidal volume and a fast rate to try to minimize lung damage while you're waiting for a self-resolved pulmonary disease to get better. Problem is the BPD is not going to self-resolve, and the lungs already damaged. So you really need to think about changing the paradigm for how you ventilate those patients from this small tidal volume fast rate to a large tidal volume and a very slow rate. We've also unfortunately discovered that there are health disequities, I guess is the right word, in care and outcomes for patients with BPD. We just published this paper in JAMA Pediatrics last year, and we found that if the mom identified herself as Black, that the chance of death or prolonged length of stay or death or tracheostomy, the two outcomes shown in A and B, were much higher for those patients, despite the fact that there was no difference in disease severity between the patients whose moms identified as Black and those moms who didn't. So this is something we really need to try to address going forward, but it is one of the things that we feared might happen, and we really need to try to figure out what caused this disparity, and then we really need to try to figure out ways of trying to address that disparity. So we really need to collaborate to understand BPD. BPD is associated with bad outcomes, but not all patients have bad outcomes. Some do really, really well. Some even go home from the hospital on room air. While other patients have lifelong alterations in pulmonary function that end up causing symptomatology well into adulthood. So where do we take our collaborations? We really need to try to figure out what causes BPD. And there's probably more than one cause. There's probably multiple causes, multiple things that happen. And I don't necessarily mean in preventing BPD. I do mean that. But the other thing that we need to think about is how do you take care of patients once they have the disease? How do you alter disease progression? How do you make that patient better? How do you maybe not make them have symptomatology well into adulthood? Those are all things that we need to work on. So we need to identify endotypes. The other thing is we need to characterize the natural history, comorbidities, and long-term outcomes of these patients. We need to characterize their phenotypes. And then we need to use that evidence, that data, to figure out how to do good clinical and translational studies that will positively impact clinically meaningful outcomes. So that's the only way we can generate that evidence that I talked about earlier, so that we know what we're doing in terms of treating patients with BPD. And we need to collaborate to reach precision medicine in these patients, or at least precision care. By identifying phenotypes and endotypes and genotypes, we can develop, hopefully, objective definitions of disease so we can know exactly what BPD is. We can identify patients at the highest risk for adverse outcomes. We don't always know that. The current definition, the Jensen criteria, or even the NICHD criteria from 2018 are much better at trying to do that, but they still only have a C statistic of about 0.79, so it's not great yet. We need to try to get better at that. And then we have to identify those patients that are most likely to benefit from a particular treatment, that old paradigm of the right treatment to the right person at the right time. And so to do that, we need to work together to develop novel and objective definitions of BPD. We really need to think about these patients for their whole life. It's a lifelong chronic disease that we need to think about. I think that in the future, just like we have transitions from pediatric care to adult care for kids with CF and sickle cell disease and congenital heart disease, I think in the future we'll have those same kind of programs for kids that have BPD, transitioning from pediatric care to adult care. We've had tremendous improvements in survival in kids with severe BPD. Now we need to build on those and really optimize outcomes, particularly in terms of neurodevelopment and pulmonary function later on in life. And then, of course, we need to utilize innovative approaches, which is what this whole conference is about, to really try to build precision therapies for patients with BPD to make them better and to improve long-term outcomes in this patient population. So with that, I'll say thank you very much and I appreciate your attention.